Good evening, guys. Welcome to our the third of the three-part series on runner's feet. Today, we're going to talk about plantar fasciitis. We're going to explain what plantar fascia is and what happens in plantar fasciitis and how to treat it and how to come out of it. So what is a plantar fascia? Plantar fascia is essentially a connective tissue. It's a fibrous tissue. This is my alarm to tell me that I'm on track. It's a thick connective tissue. It runs from the heel all the way into the toes. It stabilizes the foot. It is important to maintain the arch of the foot. And it helps loading and unloading of the foot itself. So 9 key functions, biomechanical functions of plantar fascia. There's another word that I'd like you to keep in mind, which is the windlass. That's the mechanism in which the plantar fascia works with. So essentially, when you have a force being applied, as you can see, the blue line that comes onto the joint itself, the two ends, that is the heel end as well as the toe end, begin to elongate, which causes the arch to lengthen and therefore tighten, which is what gives you the integrity of the arch itself. But when you lift your toe, something else interesting happens is that the contractility of the arch itself, of the fascia itself, begins to tighten, and therefore the joint rides up, which causes the arch to form. So the first mechanism through which we look at plantar fascia is this mechanism where the force falls down onto your ankle itself, which pushes the entire arch down like this. It collapses the arch. And that collapse of the arch is what causes a lot of issues later on. But essentially, that collapse helps tighten the Achilles tendon on that diagram. It pulls up, therefore causing this arch to become fairly rigid. And as you can see on the diagram on the right-hand corner, the transverse arch, or the keystone bone in the foot, is called the cuneiform. The keystone is what keeps the transverse arch nice and stable. There are 3 arches in the bone which are in the foot, which I did not mention to you about. One is the medial longitudinal arch, which is on the inside of the foot. There is a lateral longitudinal arch, which is on the outside of the foot. And then there is the transverse arch, which goes between the big toe and the other smaller toes. It's not a complicated diagram, even though it looks it. But what I'd like to show you is that when the foot bears weight on it, and the toe is pushing off as you toe off to walk, the joint itself begins to pronate, fall inwards. So in order for it to stop falling inwards, if you can see the diagram in A and B, marked as A and B, the force becomes inward oriented. Whereas if you want to go forward, the force is still pulling you inside. So in order for that to stop, the Achilles tendon, as well as the tendons of the back of the foot, the big muscles of the back of the foot, tibialis posterior and so on and so forth, tend to pull this up so that the force now becomes more linear where you want to go, which is in the figures in the figure C, where the line changes to C, and that is enabled by the fact that the plantar fascia works with the deeper muscles of the foot and the legs to stabilize the ankle, which is what I was telling you about previously. Now here is an interesting diagram. Plantar fascia doesn't work by itself. It also has other helpers around it. So when a weight falls on your foot on the left-hand side, the ground reaction force on both aspects of your foot, on both aspects of your foot, if you can look at the video, are high because the weight has fallen down. There are ground reaction forces that are pushing up. Now, in order for that to get protected, the fascia here and the fascia here, in help with the intrinsic muscles of the foot itself, stop it from going too far out and too wide out. However, when there is too much weight, when the world is upon you, the fascia tends to sometimes get injured. And that kind of injury tends to loosen or slacken the function of the foot itself. However, the other intrinsic muscles, the other muscles of the foot, the deeper muscles of the foot, take over and bear the burden of that, the weight itself. So one of the questions that one of the participants asked is that what is the risk of running with plantar fascia? These are some of the risks, that there are other smaller muscles in the foot itself which really only share the job. But if the fascia itself is weak, then they tend to also take in a lot greater load of that foot, which of course leads to other things which Srinand and Abhi will discuss a little later. The other, even though this seems complicated, is not. Just follow the arrow marks onto the left as it comes through. So as the weight comes on the ankle itself, there's a ground reaction force that pushes the foot up. As the ground reaction force pushes the foot up, the foot tends to dorsiflex. So the toe tends to go up a bit. So it's like this. If you watch the video, it goes up because the force comes up like this. And that's marked with the C. Now, as that happens, as that is happening, these are all simultaneous ones, the force that originally came from wants to push the heel and the rear foot down. But that cannot happen all the time, because as soon as that gets triggered, you have the Achilles tendon pull the foot up. As it pulls it up, the rear foot begins to come forward and causes a compression on the dorsal side of the foot, on the top of the foot, which is a great thing, because that is what will protect the integrity of the arch as well. When that does not happen, when the fascia is not not integral part of the foot itself, it's because it has inflammation, it has fasciitis, or it is torn, or whatever for the reason, there's a lot of strain and pressure put on the dorsal side of the foot. So these are some of the things that happens when the foot itself, or the plantar fascia itself, is not functioning well. These are biomechanical changes that happen. Here again, it's very simple to see. When the force acts upon, on the left-hand side, when the force acts upon the ankle itself, there is a reactive force that comes up. That's the B. When the reactive force comes up, the whole point of the metatarsal is to fold up or dorsiflex like this. But that ends up becoming corrected or stopped very quickly, because the Achilles picks up that force and causes tension in the plantar fascia, which is the D, which then allows for this dorsiflexion to remain planted. Okay? And that is what causes, which at a later stage, the other point that I will cover at a later stage, next slide I think, is about how it gives you better balance, better perch. So without plantar fascia, 65%, there's an increase in 65% of dorsal metatarsal compression itself. That's a lot of compression on that small joint. Reducing ground reaction force during metatarsal head during propulsion. So when you're pushing off to run forward or to walk forward, the force that acts, that is the arrow mark that comes up, the force that acts on the metatarsal is what gets reduced as a ground reaction force because of the plantar fascia. So it also helps absorb and release elastic strain during running. This essentially makes the mechanics of the foot. So the take home for you is really a healthy plantar fascia gives you a better foot mechanics. A better foot mechanics means a better foot function. In our earlier chats, we had an understanding of what a foot function is, which is the hepatic function, which is the feel function, which is the propulsive function. So a better foot function also means that there is a better ankle mechanics. The ankle seems to work better. If that begins to work better, then you have better lower limb mechanics. Because if ankle can move better, then your tibia can articulate better, then your femur can articulate better. If that happens, then your hip becomes hip acts better and behaves better. If all of these things tend to accumulate as a cascading benefit, then you have a better running mechanics in itself. This is a very simple take-home message. There are multiple things that improve mechanics, not only plantar fascia, but plantar fascia as the first as the first fascia that touches the ground. It's the first thing that touches the ground. It's the first thing that receives any information that your brain or your short reflexes get. So therefore, it is most important and critical to have a healthy plantar fascia. And from this, Srinand is going to talk to you about what are some of the things that will happen if that fascia becomes poor in health and in structure, and therefore how do we assess it, how do we clinically diagnose it, and once that happens, Abhi will take you through how do we repair it, what kind of stuff can we do, how long it will take. He will answer some of the questions that one of the participants had asked, is how long will it take to heal, and can I run with plantar fascia or fasciitis? How much can I run? What kind of loading can I take? Etc. etc. And it all depends from sport to sport as well. So between running and football and cricket, so we have 3 different sports played on 3 different surfaces, 3 different types of shoes. So Abhi and Sri will discuss more on that. Thank you so much.
All right, let's get started. So that's given you a very detailed insight into the anatomy and the biomechanics and what is vertical force and horizontal force, what is the loading force and the vertical force and the braking force. So in simpler terms, why vertical force and braking force is especially important is it plays a crucial thing in fast bowlers, because fast bowlers run up and suddenly they take that one leap and then suddenly they have to expel the thing. So if you look at the next, sorry, one sec. Yeah, if you look at this slide, you can see that I've written some numbers as 600 kilograms of force vertically and 450 grams of force negatively. So horizontally. Sorry, this is a little bit technical over here. What that means is the vertical force and the braking force are 2 opposing force or 2 frictional force. The vertical force is the force that is coming from top, which is basically the plantar fascia, which is stretching out the plantar fascia. And the horizontal force is something which is a braking force, which is trying to contract. If you remember the image of the bridge Badri showed in his previous slide, so the braking force is basically trying to maintain that arch so that you keep the foot in one place. If you didn't have this opposing vertical force and this opposing braking force, then your foot would be all over the place. You wouldn't be having a stable thing. Don't think too much about that. The whole reason I gave you that thing is to these numbers, 600 kg, just as we think of a 75 kg fast bowler. The reason why you should be awed by these numbers is that's the amount of force the plantar fascia takes. And I'll just show you how it is in different sports. This is in a fast bowler. And let's take a runner. I see a lot of participants, a lot of them are runners, so I'm quite sure this will be quite exciting for them. So as a runner, here you see there's no horizontal force because there's no sudden stop. You're running like 21 kilometers, 42 kilometers, ultra marathons. It depends. There's a lot of running. So a typical runner exerts up to 3 times his body weight. So a 75 kg runner can put up to 225 kgs of body weight per stride. So imagine your 10 kilometers takes about approximately 10,000 steps. So every time you land on each foot, so you're putting 5,000 times, about 5,000 times you're loading 225 kgs on your right leg, 5,000 times you're loading 225 kgs on your left leg. So can you imagine the amount of load? So why the plantar fascia is so important? And this is with running, and this is with football. What happens in football is, unlike maybe a cricket fielder and a football have a slightly similar movement pattern, because you suddenly have to run, you suddenly have to stop. So when a player starts accelerating, he puts about 1.2 times his body weight. So a 75 kg guy will put approximately 90 kgs of vertical force on him. But by the time he reaches full speed, or by the time he gets that full speed of acceleration, he's putting about 6 times his body weight. A little bit of the biomechanical insight over here, just to give you an idea as to how much stress how much pressure the plantar fascia is at all periods of all times. Okay. So let's move on to the clinical aspect of it. Yeah. So what are the risk factors or what are the causes for plantar fasciitis? Now, it's been shown very commonly. I mean, the first and foremost risk factor is biomechanical issues. And as you can see, what happens is reduced ankle dorsiflexion appears to be the most significant biomechanical error. Now, when we talk about the foot, we'll be using a lot of technical terms like Badri explained in his previous thing about plantar flexion, dorsiflexion, abduction, adduction, supination, pronation. A lot of terms. It can medial, lateral. It can get very confusing. Very easy way to remember is take your foot. So dorsiflexion is basically foot coming towards the body is dorsiflexion, foot going away from the body is plantar flexion. So, so just imagine this is my foot. Sorry, I'm showing it on my hand. It's easier to explain. So this is the foot, and this is the foot. If a foot comes towards your body, that's called dorsiflexion. It goes down, that's called plantar flexion. So what happens is, if you're not able to bend the foot too much over here, that shows that plantar fascia is very tight. So very tight plantar fascia makes it more prone for plantar fasciitis, and that's why it's very often seen that a poor dorsiflexion predisposes someone to plantar fasciitis. I think. One way of testing if you have good dorsiflexion is this is a very good image. Just go stand next to the wall and try to bend your knee slightly and try to lean forward and see if you can get your knee to go pretty forward. You'll have an idea. Uh, the second uh, the second issue is muscle weakness. So muscle weakness is plantar muscle weakness. Now, when we talk about muscle weaknesses, you need to understand that you have to be talking about the whole chain, right from the foot. There's something called as the kinetic chain, right from the foot all the way till the neck. But let's not make it too complicated. But because we've seen cases where it's shown that people having very tight hips or very weak glute muscles can also come in present with plantar fasciitis or what's on them. Now, I think I missed the one. Sorry, uh, 1 minute. Yeah, sorry. So yeah, so that's one thing about plantar. That's reduced dorsiflexion, weak muscle. These are two risk factors. And muscle weakness can stem anywhere. It can stem right from the foot all the way till the glutes, yeah, or even back issues can lead to it. The next important risk factor or cause is the amount of time you spend on your foot, and this has been shown to be a very high risk factor. I mean, take any of the three sports we've spoken: running, cricket, or football. This is the average marathon finish time by age group in a Western country. India is somewhere at 5 hours. We take an average of the average time spent by an Indian is about 5 hours on a marathon. So 5 hours on your feet is a long. Just imagine that number I gave you. Every time you're putting in like 225 kgs worth of force on each foot. So that is a thing. Or if you take a cricket match, even if you take a T20 match and you're on the fielding side, you're still spending a lot of time running up and down. Football, you spend about 90 minutes on the pitch, and it's so many sudden movements and things. That's another risk factor. The third risk factor is shoes. Shoes. I mean, come on, it's not only worn out shoes. It's not only worn out shoes. It's also the type of shoes. For example, footballers have to wear a different kind of shoes. You can see on the screen. Cricketers have a different kind of shoes. Runners wear a different kind of shoes. At football studs, what happens is that because these shoes are so firm and they're quite rigid, it doesn't allow a lot of movement for your feet. So that can also play a big role on it's a lot of repeated trauma to your foot, and that can cause a lot of plantar fasciitis. Or if you look at the cricket shoe, those are nails. You can't put a nail onto a soft sole. You have to put it into a hard sole. If you look at a fast bowler cricket shoe, it will be very firm, and right? So Abhi will be able to give you a better insight into that. So when you're loading your leg on such a firm surface, that can also cause a lot of plantar fascia. Worn out shoes, everyone knows worn out shoes. That's a very, very common thing. As you can compare the right shoe and the left shoe, you can see that the right shoe is slightly worn out compared to the left shoe. This is also a very common risk factor for developing plantar fasciitis. The next thing is a running surface again. Again, nowadays football is played on an astroturf, which is a synthetic material, which is not the same as, even though it looks all green and nice, it's not like running on grass. It's not like running on grass at all. It's running on plastic, and it causes a lot of, uh, let's say, a lot of friction and a lot of issues. Cricket pitch. Look at that pitch. That's not something I would like to run on, but look at that. That looks so hard and thing. But you have either you have a fast bowler running onto it when he delivers his ball, his feet is landing really hard onto that, or you have a, even if you're a batsman and you're running in between wickets, you sprint 22 yards and then you have to suddenly stop, turn, and then you again have to get back in the opposite direction. So all this puts you at risk for plantar fasciitis. Road running not so bad per se. The road's relatively soft compared to running on concrete surfaces, and but what's happening these days with all the white topping happening all over Bangalore and all of it, they're more likely that we'll be running on concrete surfaces than on the road. I think even it still shouldn't be so bad if you built up your training for that. But these are just common risk factors. Unhappy feet. Uh, yes, you can get plantar fasciitis with a high arch as well as a flat arch, and or no arch rather for that matter. What happens in a, if you see these images, this is a normal arch. You can see the plantar fascia is in a neutral position, if you can say that. But when you see in the high arch, it's contracted. It gets contracted over here. So plantar fascia is very tight in that thing. And if you see in the flat arch, it's kind of stretched all the way, but it takes all the load every time I land my foot on the ground. So, and also it's not only that, it's not only the amount of contact that's happening away, it's also that flat arch people are more prone for overpronation and high arch people are more prone for underpronation or oversupination. And these are also improper biomechanics, which eventually lead to the development of plantar fasciitis. And this is the next cause. Uh, Training errors, very, very, very common reason. Too much, too soon, too hard, too little rest. People get carried away with training errors, and I can understand the thing. You've done for the first time in your life. You've done a 10K after sitting on the couch for such a long period of time. Now you've done 10K, and then now you have the peer pressure. You're like, okay, now I've done 10K. I'm going to do a half marathon next. And within a year, you've run a marathon. And there are people who've done that. There is no doubt. There are people who've done that, gotten away without injury, but unfortunately, not all of us are. I think. My advice for you in such a situation is to get into a structured training program. There are many, many training groups all over the city. Jayanagar, Jaguars, pacemakers, runners. A lot of running groups. Get into a structured training program. Make sure you do it under supervision. That's very, very important. Uh, there are some honorable mentions. These are very important points, but when you look at it from a sports perspective, but since a lot of other recreational runners, a lot of other amateur runners also, these play a big role. Being overweight is one. It's been shown that the incidence increases when your BMI is greater than 30. Then there's something called as the Q angle or the quadriceps angle. This plays a significant role in women. It's there are studies that prove it and there are studies that disprove it, but it's been shown that it's been used more as a prognostic tool these days. Diabetes, other metabolic diseases, post surgery, in case somebody had a plantar fascia surgery or some sort of surgery to do with the calf muscle or something, that can cause it. Vocation, doctors, nurses, constables, teachers, dancers, all these people are standing for longer periods of time, so that can also predispose. Imagine, I mean, I personally know a couple of cardiothoracic surgeons and gastric surgeons who run like 6-7 hours a day and then they go operate for 8 to 10 hours a day. Imagine the load on that. I mean, incredible. Hats off to them for doing it. Different leg lengths, yes, this can also compromise and lead to it. That's the etiology. I know I spent a lot of time on the etiology, but usually the key to a successful treatment of any medical issues, making sure you know the cause, right? Once we know the cause, what is the cause and what's the root cause of the pain, is very easy to make your treatment. And now, typically, plantar fasciitis, there's something called as insertional plantar fasciitis and something called as non-insertional plantar fasciitis. Now, the plantar fascia inserts at the back of your heel. It starts from here and spreads across and comes to the top, as you can see in this. And that is the most common area of pain. About 52% cases have come over there. That's the insertional plantar fascia. It's happening where the plantar fascia is inserted into the calcaneus bone. Otherwise, it can also involve this, what we call this as the medial longitudinal arch or the lateral longitudinal arch. It doesn't have to necessarily come at the heel. This is called non-insertional plantar fascia. These are the three most common areas of pain. Just to give you an idea, because very often people think plantar fasciitis means only heel pain and nothing else. So it very often gets misdiagnosed and what are your symptoms? When do you know? Do I have to go to a doctor now, or do I have to go to a therapist now? Do I need professional advice? What do I do? How do I decide this? Um, Typically, remember those three areas I mentioned. So pain on any of those areas with the first few steps in the morning or after a prolonged period of inactivity. This, it usually gets better as the area warms up. It gets better. This is the classic symptom of plantar fasciitis. Uh, Pain, and yeah, the opposite can also happen. Pain after prolonged activity can also cause. Is also a symptom of plantar fasciitis, because in case you already develop micro tears or micro strains and all of that, what happens is repeated trauma, repeated tapping, repeated landing can increase the strain over there, increase the size of the tear, and that can also cause pain. Limping, you're not able to, as you can see in the picture, is the patient on the person on the is not able to load the left foot. The left foot is off the ground. Limping is one. Occasionally, if along with plantar fasciitis, if a nerve is trapped or something similar, you can also have foot tingling or burning. These are the symptoms. What are the signs? As Buddy spoke about the windlass mechanism, there's also something called as windlass test. What the windlass test does is you put the plantar fascia into maximum stretch. So if you want, you can try this along with me. Ideally, you want a therapist to do it. So basically, you take your foot to the with you over here. Make sure it's at, if you dorsiflex it, so you pulled it to your body. So this already stretches the plantar fascia over there. And from here, I want you to pull up your big toe further. So now you given a maximum stretch on your plantar fascia. And from here, what you do is under the big toe, you press. This is typically what your therapist or someone might do to elicit the pain. And if that elicits the pain, that's very diagnostic of plantar fascia. Sometimes you don't even have to go to that extent. You can just place your foot on the floor, pull up your big toe towards you, and that itself will elicit the pain. These are the typical signs of plantar fasciitis. Uh, how do we diagnose this? Is usually done clinically. You don't need any imaging to diagnose plantar fasciitis. But there are other causes of heel pain and like heel spur or calcaneal fracture or nerve entrapment or Achilles tendinopathy. A lot of medical issues over there. You might require imaging to rule out these other causes. Treatment. I mean, like, imagine spending so much time for just two points on a slide, and now we have a slide with 1, 2, 3, 4, 5, 9 points. No, don't worry. Just that's the reason we spend so much time on the etiology, so we can just breeze through this. Working on the biomechanical errors, what we spoke about dorsiflexion. Work on your dorsiflexion, improve the range of movement, and that's like basically stretching out your calf muscle, improving your calf muscle flexibility. That helps with your plantar fasciitis. Strengthening of the plantar fascia muscle. There's something called as high load strengthening, where you keep a small towel underneath your toe and then you lift it. That's one reason. Mobilization, manipulation techniques, the various physiotherapy modalities out there. A lot of people do, like the subtalar joint distraction or the posterior talocrural joint mobilization. These are different joint manipulation, mobilization, footwear correction. A footballer might be wearing a shoe size too small for him, So his foot is you kind of contracted and something like that. And then or a fast bowler might be wearing just regular shoes and so he already has a flat foot and the whole thing is taking the load of the hard surface, wooden surface. So you might want to put an insole over there. Insole is the next thing. Correct training program. We mentioned this. Night splints. Not a big fan of it, but some people have used night splints where they fix your leg in a splint position like this and let you sleep the whole night like this. But it's not very popular because people can't. It's very hard to sleep like that. Imagine doing that. You need to do it for 3 to 6 months on the trot. A very bad compliance with that. Taping, acetic acid. I know tophoresis. Sorry about the tongue twister over there, but some people have used it. Again, it's not used very commonly in India. And there are other various technological therapies like extra shock wave therapy, extracorporeal shock wave therapy, 10x fast procedure. These are different modalities that people use to send vibrations over there, basically try to dissolve the fibrous tissue and try to help it. The last part is surgical interventional methods only if conservative method fail. You can inject a steroid, PRP therapy, stem cell. PRP and stem cells are doubtful; they're yet to be proven, but these are options. Surgery is a last option, like fasciotomy or either endoscopic or just open. That's about it. Now I'll pass it on to Abhi.
First and foremost, I think what we need to understand is the whole fasciitis scenario is a very, very highly inflamed fascia under the foot is what is presenting pain, this referred pain at the heel or different parts of the feet actually. And that's generally caused because of a failure at the arch. And it's not, and because of a failure of managing the body weight through the gait cycle as well. This could happen because of n number of reasons. It's not necessarily that the foot function only failed. Many a times what I see is the foot function has been trying to handle the deficits that your core and core, which in terminologies, which is very highly misunderstood, core in our terminologies, but which actually is, which starts from all the way from the pecs and runs down all the way till the knee, that whole region, the whole glute and abs and all of them working together, the synchronization of these things working together as the function of the core is really, really the critical element of how the foot can handle the load put on it. If the foot alone needs to handle the rest of the load, like in one of the pictures Buddy showed, the ground reactive forces, if it has to handle all of the ground reactive forces, even if your foot's doing a great job, it'll only take you that far. Maybe one marathon, two marathon, third marathon begins to fail because your core is not contributing in the force absorption and management of the force. It needs to be in unison with the core. So that's why when we look at correctives, we not only look at managing the symptoms, which is a very highly inflamed plantar fascia, but many a times I keep saying I see people being given anti-inflammatories and then they do ice massages and rolling and then they go back running. But the core of the issue was not that the inflamed fascia. The inflamed fascia is only the symptom of a deeper lying issue, right? You need to fix the deeper lying issue. The deeper lying issue is looking at the foot mechanics and the reason for the failure of foot mechanics. The reason could be a number of things. It could be genetically you were born with a lax arch, so it is not absorbing. Genetically you might have been born with a higher arch, or it could be that the force that the foot has to handle was so large because the core was not helping out in the process. You would see a failure in the foot mechanics as well. So you see in such cases they would normally have a great arch when they're standing in a static position. When they walk in a dynamic gait, you would consistently see a failure. So if that is happening in just a walk, so for you guys to understand where do you fit into this gamut of really bad, born with really bad feet to a dysfunction of the foot that happens due to movement or in a dynamic plane, all you need to do is look at your foot, look at your arch when you're standing and then when you're walking. If you see your arch fail, you'll see that most of the times that your foot is enabled to synchronize with the rest of the body to kind of handle the load that you're putting, and that's only for your walking itself. then you can imagine the larger amount of forces that Sri spoke about when you're running. So generally that is the core of what needs to be looked at. Where is the deficiency? Is it just that the foot in general is not working? I will come to the footwear aspect of it, because a very, very, very big aspect of plantar fasciitis is the footwear. And in all the three sports that you guys spoke about, especially we looked at football, we looked at runners, and looked at cricketers. In all of these things, the footwear is really the main cause of it, because the tendency of a lot of the footballers I meet who play football on the beach have hardly seen issues with plantar fasciitis. And that must be a direct correlation for that, because you can see that because of the nature of the sport, and because they keep running barefoot on the beach, the foot is allowed to proprioceptively get a feedback from the sand, which allows for the foot mechanics to develop. So inevitably, you will see people from the coastal regions who play or do activity on the beach having better foot mechanics because of this. And now that we live in concrete jungles, we have no opportunity to actually do this barefoot. And even if it is barefoot, the load and the shear forces that are there on the foot when you run on hard surfaces is quite large. So that becomes an issue here. And that's why we begin to wear shoes to support it. And we'll consistently see there being a failure of the shoe to support the foot mechanics itself. So when you go to buy a shoe, you need to, one, look at how your foot is functioning by itself without any support. If it's doing great, then you need to buy a shoe which supports the great function your foot is already doing as well. It's not one or the other. You can't just substitute one with the other. Sometimes I see with people who have already having failure at foot mechanics, we can actually use structured footwear. Orthotics is a customized orthotics, one way to go, but you also get different shoes for different type of feet, which can allow, it's basically facilitating better mechanics to the foot. It's not doing everything. It's just facilitating better mechanics. Okay. So having this as a base, I'm just going to go by how we look at the rehabilitation work. I'll also tell you a process of rehabilitation that you can do for plantar fasciitis as well. How long does it take? And what are the conservative and surgical options if there has to be? Because there has been times when people have been using anti-inflammatories and running, and the load on the tissue was so high because they were around anti-inflammatories and painkillers. The pain was numb. They did not know, and they had a rupture of the fascia. So that's why it's extremely dangerous to continue high levels of training just by numbing pain by taking medication as well. So that's where there has to be a good understanding of how we can optimally load the tissue when you're under pain medication as well. So this is a critical aspect that I have seen consistently. People come with recurrent injuries, and sadly, since it's not the easiest way. I have not made it very easy for people to reach me for any number of reasons, but normally it has been that people have suffered with this injury for about a year or even more, and then turned up at our doorstep. And then all that I see is they've been given conservative management of the tissues, but nothing to integrate the biomechanics of the foot with the core. So that's where the lacking is. So as correctives go, this is what we're going to address. How do we look at local issues, and how do we integrate into the global movement? Okay. I'll just go by what we were speaking about just now. If you can see the first image here, this is the whole fascia which starts around the foot, which is the contributing factor. So you will see that a lot of them will present with pain and tightness in this entire chain, the whole extension chain, and doing release work and myofascial work or dry needling or cupping, whatever. End of the day, all of these modalities are focused around mobilizing fascia and improving blood flow to this fascia. So it could be, it's only dependent. A lot of them keep asking me which is the better way to go about it. My answer to that is, if the person administering the therapy is good at what he does, it doesn't matter. At the end of the day, all of it does the same thing: improve blood flow through the myofascia. And like I can show you, this whole chain, the hamstring and the calf and the gastroc and all of these regions being tight will cause an added strain under the foot, right? So it can add for shortening of this whole fascia, and then hence there is tension under the foot. So it would just be referred pain presented there. And so you will have to do complete work all the way from the lower back, if not all the way from the neck. I would generally go by doing this entire chain, but I would normally look at other contributing factors. So if I'm looking at factors at the foot, I'm obviously going to, and especially under the foot, I'm obviously going to go through this entire chain, look at the compensatory patterns and begin with the chain and deal with all the tightnesses, because that's when you get a complete fix. That's why we see a lot of them who have come with doing a lot of yoga and they keep saying, yoga felt better. But it's like doing only the first part of it. Like right now, the soft tissue work that I'm showing is just 10 or 20% of the work that needs to be done. Similarly, if by just doing yoga that is basically stretching this fascia out, you will probably get this whole myofascial chain to be stretched out. Yes, but it would take longer because it has not been manipulated and then added with yoga. So generally, both things go hand in hand. But you would see that once you start running again, it will just come back because the core of the issue is not. So this is just 20% of the work. You need to address what part of this chain is the factor to having plantar fasciitis. Inevitably, it will be generally at the foot itself. The foot is under extreme amount of load because the rest of the core and the other stuff is not supporting it. So that's what it presents as. And I have this last image on this corner, which shows sites. I think one of the I saw a question on the chat room which spoke about heel spurs. Somebody asked about heel spurs, and that's why if you can see this image here, you will see that you will see that there will be pathologies that present, or rather the referred pain present at this site, which can be of different issues as well. And this last scenario where I've been plantar fascia, this is on a high tension fascia, will start showing changes because there is a lot more osteoblasts, which are nothing but adaptations from the bone to handle the extra load that has been exerted at this point because the fascia is tight. It's been pulling at it, so you start developing heel spurs at this point because the adaptation of the human body to load is, when it's a muscular tissue, is to just we have microfractures and it rebuilds. Same way in the bone, the osteoblasts begin to calcify that area because there's a higher stress at that point, and you start seeing heel spurs there. So again, the fix for it, and if it's a very structured, hard pose and it's beginning to impinge on something, yes, one of the easiest ways is to get, from a bone spur perspective, if it's a large spur and it's impinging and it's creating a structural impingement, a minor surgery which we can shave off that point, but still by just doing that, the correctives is not done. You're again in the same gamut of 20% of the things that you're looking at. You remove the heel spur is going to come back if you don't treat the myofascia. You have to treat the fascia, you have to treat the chain, and the chain that will help integrate better. That's when you'll not see a recurrence of the heel spur. So the heel spur being there is just a sign of a very highly impacted point due to a failure of biomechanics, or an impacted point where there is large amount of force that the foot has to handle. So the foot adapts in that way. So I hope some part of the heel spur question that you asked is answered here. But if you have more about the same thing, we can re-answer the same question if I've not answered it over here. Okay. Coming to correctives, like I said, go from local aspects, examine the local aspects. One of the most simplest things, and I had since I think Srinan spoke about me and cricket, because when I used to play, one of the issues that I had terrible shin splints at one point, which we addressed in a previous webinar as well, but also started presenting with a lot of heel pain as well. And inevitably, it was because the footwear that I was wearing, and when I used to bowl 25 overs in the day, and I had successive games, it consistently come back. There was so much of all the physios used to do a lot of myofascial work through my post tib, get all of the tissues that are getting tight working, but then I would go back to bowling and I have the same thing. And this was in the middle of the season, and that was tough because at that point to actually try and take time off becomes difficult. It's same as any runner when he's having in the middle of his preparation to a marathon, you will see this pain present, and then you will need to have you will have issues on how to do the corrective work. One of the easiest ways or a quick fix method was to support the navicular like this insole here is. But then again, like we've spoken in the previous webinar, a lot of adaptation time is required to an insole, and it's not just wearing it and walking around. Wearing it and supporting the with a lot of massage work under the foot. And one of the most easiest ways to handle inflammation, especially for plantar fasciitis, is just putting a bottle of water. I think many of you guys know this. Putting a bottle of water in the freezer, let it harden, and then you can use that once it's hardened. Use that to ice massage the undersurface of the foot. So you can, like I've shown you here, having this ball in different positions. You can actually have the bottle and use that position to roll out that massage that fascia. And because of the cold, and it will actually numb the pain there is in that area, and we can actually use it to bring down the inflammation. Again, that is just 10% of the work, right? You cannot go back running just because pain went away. It's still in there. You've not corrected the biomechanical defect. That's why after doing the corrective work via an insole, you will be pain-free. Once the inflammation is handled, you might be pain-free walking around. That is if the insole designed for you is accurate to at least 80%. And so one of the other options is just getting the fascia to kind of do concentric work, just build a lot more contractile tissue so that the integrity of the fascia can improve. So you do a lot of flexion work. That is, we do a lot of plantar flexion work here, so I can help build some tissue density so that the tissue can we can help it recover. And normally concentric work allows for the contractile proteins in the tissues to come together and to become thick. This is normally the common way. Obviously, we can do different ways to stretch out the fascia. I've written over here. Just we got to make sure that we open out the tissues there, do the stretching. So that's, if you think of that as phase 1 is handling inflammation, then phase 2 is it's not really phase 2 part of phase 1 itself, or rather step 2 in phase 1 is getting the tissue density to improve the fascia, the thickness of the fascia to improve by doing concentric work. At the same time, after you do that, you can begin lengthening the tissue. There's a conflict there always, because a lot of them begin stretching along, especially when there is so much inflammation in the tissue, and they end up irritating more fibers, and it just gets worse. So you need to understand, initially the conservative way for this is really, really important, because it's a high stress tissue and it's loaded all the time. It will go to a state where you might need to offload your foot for a period of time so that the inflammation can come down, and actually offload the leg for at least, I've gone to extents of actually offloading the foot for almost 7 to 10 days, but I've got them to do some pull related activity during the recovery period where they're doing 50% of their body weight work. But that's extremely important for those fascia to kind of relax and come together before you can do any other work. A lot of them will still be in pain. Don't look for changes just because you're in pain and you start doing strength exercises. And if you're going to be stretching the fascia again and using the same old biomechanics which caused the thing, you'll only see a return of the injury happen. And so that's why so many of them keep struggling with the same thing for a whole year, instead of just looking at how they can offload it. It's generally a 9 to 12 week thing, but in severe cases, it's gone up to about 4 to 5 months as well. But that's because initial management was extremely, extremely poor. Coming back to the correctives, we do, like I've shown here, we do a lot of the local work where we're supporting, fixing the local issue at the foot, then doing the corrective work, then again, integrating the foot mechanics with the rest of because the tissues and the muscles at the foot aren't large enough or big enough to take the kind of load a running or a bowling or a kicking or a running in football or change in direction presents. You need to engage the foot mechanics along with the entire chain, like I showed you earlier, and then make sure that the core elements, which is the ab musculature, especially the TA, which is the deep lying muscles, which is the important pelvic stabilizers, which is at the floor of the pelvis, need to engage them well along with the glutes, like I've shown you. This basically does that. We kind of load them bilaterally on both foot and then move into unilateral progressions where you're building this whole chain up. As you can see, doing this foot elevated method can actually help offload the tissues as well. But it's helping them recruit better along with that whole chain of the plantar fascia under the foot. We can integrate that entire chain back into the movement pattern, but only when you have the whole core region, this entire region working to support the foot, and you help translate that into movement, into running, is when you'll see that the issue is completely solved. Hence, the entire 12-week program. You will normally spend a lot of time, up to 3 weeks, managing the inflammation, depending on the severity of the case, yes. But post the inflammation is handled, then you can go by the whole thing. I love doing a lot of eccentric work for the hamstring, because the hamstring we are packed up massively in this by helping the hamstrings function, which is generally eccentric strength. It generally has to process a lot of eccentric strength to handle the load while running. Due to a failure of the eccentric strength is when you'll start seeing tightnesses in this entire chain, which ends up as plantar fasciitis as well. So there is so you need to understand, and we need to assess. You need to go to a therapist, or you need to go to a movement science person who can look at what are the causative factors, and then plan your corrective measure. Without having an approach from that angle, you will not see a corrective. You have a 50-50 chance of it getting better otherwise, because it might work, something work, and it'll end up with probably a recurrence of the injury after you do a certain amount of mileage, or after you go back to bowling. So initial management and helping you recorrect and retrain your patterns, and looking at different musculature, which will provide for the mechanics of movement, and look at what the muscle functions generally need to provide to movement, is also important. That's why the eccentric loading, like I mentioned here. So this is just a brief framework out of which you will probably end up having no pain and regular movements. But then if the issue lied in the foot mechanics because of failure of footwear, you have to get. And one of the issues I see mostly in Bangalore, or I've seen this elsewhere as well, but because I played football from a young age in Bangalore, I've seen that a lot of them buy footwear from, I don't want to mention names, but as much as Decathlon has provided for a lot of footwear to a lot of people, there are a lot of brands within that which come under the more cheaper segments, which do not do much for assisting foot function. And you'll see a failure because it's not supporting your own foot function. You'll see a failure there, and then you have a host of problems in your foot. And there's a lot of studs that people buy from that. There's Nivea and a few brands that footballers keep buying. Worst thing that you can do is Star Impact, terrible shoes which cause a lot of issues, but it's in the cheaper range, so people buy. You need to understand investing. If you're a person who runs a lot and you have a sport that runs a lot, the biggest investment has to be on footwear, because there is a reason why the Nikes and the Adidas's and not even Reebok, but even Asics and a few big brands, they cost so much because they spend a lot on the R&D of the same thing. So that is why it supports your foot mechanics. And they have made, and if you go to brands like Brooks and Asics, you'll see that they have shoes for different type of feet itself. It's going to support your mechanics. So it's really, really that point where you start seeing, if you don't provide your feet with that adequate support, you'll see that the failure will begin to happen from that point. And like always, I've kind of put up a slide where we've seen evidence on what has happened. I put this thing one point here where people said, and it was a question asked to me as well, do you think it's just that people wear orthotics and that gives a sense of correction and he feels psychologically better and that's why he goes? No, this was a paper. You can kind of go back and search for the same thing. You will see that this was a study that was made for about 50, 60 runners, and because they had actually been on insoles and they had actually better foot mechanics is why it is the reason why they had weeks of no pain, which hence made them feel better psychologically and hence loaded it better. It was not a pseudo-psychological effect at all. So that's, you have a lot of things that support the claim for using orthotics, but I always say use orthotics with caution, simply because you need to help adapt to that insole, and that itself is an 8 to 9 week period. And like you can see here, the phases that I spoke about, you do early loading, but early loading post managing inflammation. But if you have options like pool and things where you can do partial loading, that's where optimal early loading is really, really important. So you can help these contractile tissues come together and form good thick fascia again, so that, because it would have become brittle because of consistently being inflamed. So by doing this work, you will see that you can move on. Once this is managed, you move on to doing ROM based stuff, strength based stuff, like I showed you earlier, and then you start integrating your sport specific action. So when it be bowlers, yes, I would suggest you need to start being able to run first before you can actually run and bowl. You need to be pain free at all high intensity activity, from jogging to 80% running to high intensity sprints, deceleration work. You need to do all of that as sport specific work that you can do, and at simultaneously, but you need to look at the biomechanics in which you've been bowling, because half the time the bowling mechanics of your action is the reason for the failure. If you do not look at your biomechanics, and if you're not looking at how the foot is failing because you're taking all sorts of angular rotation from your run up into your action, and you'll see that you will see that you might present with pain because your body is having to deal with all these rotational components in your action when you're in your back foot landing, especially, or when you have two long spikes and you're bowling on really hard surface and there is a lot of rotation in your front foot. You will start seeing issues from this as well. So there are a host of things. Without fixing the biomechanics of the action, you will consistently see this. You might be able to run, but you will not be able to bowl because you'll see the same pain come again, because you haven't gone to the core of the issue. The biomechanics of the bowling action was the reason for it, right? Same way, biomechanics of running, if you have not fixed the core of the issue, and then you do return to sport, you start doing different. If it's cricket, you do blocks of bowling, you do 6 overs and 4 over blocks, and then you can increase your bowling load progressively so that your body has time to adapt to the new chain and not run back to the last bowling load that you did. So you have to progressively build on it and help go from nets to partial match situations to full match situation. That's when you have completely done. Same way for my marathon running as well. Your mileage, you cannot go back to the same mileage you were doing. That is extremely high load. So you will need to stagger that mileage and make sure that you consistently have checkpoints where you have someone to reassess if your inflammation is coming back. Is there any because old patterns? Because the moment you have a structural failure, because when you're fatigued and you're running, there will be a structural failure that comes with it. If there is a structural failure comes with it, you will see that you will go back to your old patterns again. So to prevent that, you will need to you need to make sure that you have done the right strengthening and integrative work to running as well. So what tends to happen? There is a pre-injury prevention phase, which is generally done in proper performance systems where we have consistent testing even post it. So my suggestion is, even after you start running, make sure you have checkpoints that you've put to go and reassess your biomechanics, reassess your the tissues and movement mechanics with a movement science guy or therapist. Make those blocks even as you do it, and make sure you get these things, because you're really prone to rolling back to old mechanics the moment a structural failure happens. So even after you start doing your old load or you're back to full fitness, you need to make sure that you have touch points with your therapists or, like I said, your practitioners, to go back and see if you are sustaining with the new mileage. Is your body sustaining? That's really an end-to-end thing. So if you have all of these components in your rehabilitation process, you will see that the end result is that you will not have a re-injury. And that's really the most important thing, because every time a re-injury happens, the tissue is disrupted further. The rehabilitation time generally is doubled or even more, and inevitably it ends up with you stopping an activity, and that would lead to stopping any form that gives you the enjoyment of running or anything, right? So that's something that we had to address normally with re-injuries, especially. It's really, really bad, and that's what we need to do.